Okay, so we're picking up, this is part two of the cardiovascular. I'm going to pick up the pace a little bit just because we'll never get through with this. It's such a long chapter, and I want to just make sure that we cover the parts that are the most important for you to understand. So far with angina, we just discussed angina earlier. Angina is when you're not getting enough oxygen to the heart. For an acute attack, the number one most common medication that's used, and it's a medication that people have. They carry it on their person. It's in the amber glass bottle with a tin cap lid. You put one under your tongue. You can repeat it every 5 minutes, no more than 3 doses. It's got NITR for nitro, like nitroglycerin. And then, so it's used to treat an acute attack. That means whenever you're not getting enough, if you don't manage to get enough oxygen to your heart, then it leads to myocardial infarction. That's when you have muscle tissue dying in the heart. Then the second case where you see the angina management is prophylaxis. So once somebody's had congestive heart failure or had a heart attack or a history of angina, they're going to be taking medications to prevent having another acute attack. And what's real important with the nitroglycerin products, we have nitroglycerin patches that you wear, one patch every 24 hours, but you only wear them, for example, in the morning, you take it off at night, discard, and you go 8 hours without wearing a patch, and then you put a brand new patch on the next day. So those are the most important parts. Now, arrhythmia. All arrhythmia is just an abnormal heart rhythm. That means your heartbeat is not normal. So we have something called a sinoatrial node. That's kind of like the generator. That's the powerhouse of our heart. That's what's responsible for how many times our heart beats per minute. You actually have on your final, there's a true-false question, but it says something like the sinoatrial node is responsible for your heartbeat rate. Whenever you hear somebody talks about a pacemaker, so somebody's sinoatrial node is no longer working efficiently for whatever reason, they put in a pacemaker. Ectopic just means it's externally. It's not something that's endemic to the body. It's something that is artificial, and it's in addition to, but whenever a person has a pacemaker, it's always going to be an ectopic pacemaker. And all it is an artificial sinoatrial node. Bradycardia. Bradycardia means you have a lower than normal heart rate. So if you look up, well, normal is 70 to 80 beats per minute. Your heart rate, how many beats your heart beats per minute, it's going to fluctuate throughout the day. Like if I pass out a pop quiz, your heart rate's going to go from 80 beats per minute to 100. You have a burst of adrenaline, and so it'll cause your heart to race. Whereas whenever you're more relaxed, your heart rate slows down. Very, very athletic people, their normal heart rate might be 60 beats per minute. Whenever they're really pressing themselves hard, athletes will work their way up so their blood pressure, their beats per minute can be 130, 140. You got to be careful not to exceed that, because that's when you can end up with a heart attack. So what is elevated? What's increased heart rate? Tachycardia. And always just remember, we think of what happens if your heart's beating too fast. You have a heart attack. Tachycardia. Tachycardia, that's too fast. The heart beats too fast. So we have a couple of different classes of medicines that we use to treat. Membrane stabilizing agents, potassium channel blockers, beta blockers, calcium blockers, lanoxin, and atropine. Out of all these, there's actually just a couple that you need to know. So we're going to go through them pretty quickly. The membrane stabilizing agents, what they do is they slow down or decrease the amount of sodium going into the heart cells. And the amount of salt is what's responsible for conduction, or the ability to generate action potential. These are the drugs Quinadex, which was one of the drugs on your lists, Norpace, Tambicor, xylocaine, procainamide, Rhythmol. And so for all practical purposes, just being familiar with this is important, but you really aren't going to be held accountable for memorizing this. These are reserved for life-threatening arrhythmias. Disopyramide, it's anticholinergic. Anticholinergic drugs have what are the side effects? So anticholinergic We have that anti-slud, anti-salivation. That means your mouth's not going to water. Anti-lacrimation. That means you're going to have a difficulty with tears, your eyes dry up. Anti-urination, anti-defecation. So you have difficult urination, difficult defecation. There's another saying that's I can't see, I can't spit, I can't pee, I can't poop. And the reason those are important is there's a whole lot of drugs. Once you know, just all you have to know is they have anticholinergic effects. You know what the anticholinergic effects are, and so you'll know automatically what to expect. With quinidine, its main concern is thrombocytopenia. So just so you know, quinine and quinidine used to be available for purchase without a prescription. Quinine in particular, it's very, very useful for leg cramps. And so when I was practiced years as a pharmacist, it was very common for people to come into the pharmacy, they just come to the counter and ask to buy a bottle of quinine. The problem is you have to regulate, you have to check somebody's blood cells at least every 6 months. Thrombocytopenia, it just has to do with, just like the word anemia, it's when you don't have enough, and this has to do with your white blood cells, but it's just something that has to be monitored or measured. Then the potassium channel blockers, you rarely will hear these. Once again, it's life-threatening arrhythmias, and they work just like the sodium. It just decreases the potassium into the cells, which delays repolarization. Cortisone. So this is the one that's the most common. This is in your drug list, cortisone, amiodarone. And of all the things, like I'm going to try to tell you because there's so many slides, this is such a long presentation. You highlight this, cortisone pulmonary. So cortisone, it's amazing. It comes as an injectable. If somebody's in a hospital emergency care treatment center, they're having a heart attack, their rhythm's off, they'll get an injection of cortisone. Whenever they're discharged from the hospital to help maintain the heart rhythm, they'll be placed on cortisone. But you have to do continuous, like every 3 months, respiratory function tests because it can cause damage to the lungs. So cortisone, and it's got darone, that's lungs is a side effect. Multec you don't need to worry about, but it's a darone. And then there's dofilide. Beta blockers, channel blockers. So with the beta blockers and calcium channel blockers, you're going to notice you're already identifying, and it's by virtue of how they work. But beta blockers, they slow down the rhythm of your heart. They slow down the power with which the heart muscles thrusting blood, which in turn lowers your blood pressure. But when it does that, it's also helping with the rhythm. Whenever you're slowing down the contractility of the heart muscle, you're helping to regulate the rhythm of the heart. And basically the same thing's happening with calcium. Now, lanoxin, this is a drug you need to know, and you've got to remember. It's because it's the only one of its kind. There's not another drug like lanoxin. Lanoxin, what's it used for? It's used to help regulate heart rhythm. It's used after somebody's had a heart attack. It's used after congestive heart failure. If you'll notice, it's got OXIN. It comes from the foxglove plant. And it was originally discovered because it's a poison. And you'll notice there's a lot of movies where they have to make somebody look like they die, and they don't really die, but they just look dead. Well, they'll give them this foxglove. They have to give them just the right amount. It slows the heart rhythm down so low, so slow, that for all practical purposes, the person appears dead. And as long as you don't give too much, then eventually their heart's going to start pumping back like normal, and they'll come back to life. But foxglove, it was originally discovered because it was a poison. And people notice if you have a pet or a little kid that eats a weed and dies, people notice it's poisonous. But they also noticed how it worked, and then gradually they realized the benefits it has on the heart. However, keeping that in mind, it's very potent, so it's dosed in micrograms. Now, I saw when students did their cards on lanoxin, there were a couple of students who wrote down 125 milligrams. No, one of the main points, if you're going to put a star or a highlight or glitter or something, you want to put down lanoxin, digoxin. It's dosed in micrograms. So you're either going to see 125 microgram or you might see 0.125 milligram. It also comes as a 0.25 microgram or a 0.25 milligram, and then it comes as a solution or liquid to drink. Its main side effects are nausea, vomiting, diarrhea, and those are also warning signs that somebody's taking maybe a potentially dangerous dose. It also, it's associated with, they see stars or halos or bright, colorful lights when they close their eyes. But it's nausea, vomiting, and diarrhea are indicators that somebody needs to have a doctor check their blood level, because it is so poisonous. It's dosed in micrograms. If a person forgets whether they took a dose or not, they take another dose and then they end up overdosing. You can kill yourself from just a simple mistake like that. The antidote, bind. Well, this is digoxin, DIG. And what do you want to do as an antidote? You want to bind that doctor, so bind. Atropine. Now, what does atropine do? Atropine is used. This is just the opposite of almost all the other drugs we study. This is used whenever somebody's heart is not beating fast enough. So if somebody's in a car accident and loses a massive amount of blood, there's not enough blood circulating, and their heart's just not able to have it. It doesn't have enough blood coming in or enough leaving to have that same contractility force. So it starts slowing down, and the slower it gets, the slower it gets. Well, then eventually that leads to death. So what's it called when your heart rate's slower than normal? It's bradycardia. So atropine is used during bradycardia. It's when the heart rate is less than 60 beats per minute. So this is one way, if you work in a hospital pharmacy, especially in the crash kit for the cardiovascular heart, you're going to have several vials of atropine. What's heart failure? Heart failure is just a term that represents a degree that the heart is not operating at a level that's considered acceptable functioning level. And so it's a chronic. What's chronic mean? It means once you have it, it's only going to continue and get worse. It's never going to heal or recover. Progressive. Progressive means once you have heart failure, it's just going to get worse progressively. It gets over time, it's going to get worse. The heart's no longer able to pump enough oxygen-rich blood to meet the body's needs. Symptoms: shortness of breath, fatigue, edema. What's that, a funky called edema? Edema is swelling, that's fluid retention. Usually you notice it in your ankles and then maybe your fingers and hands. Exercise intolerance. Well, of course, if your heart's not pumping out enough oxygen-rich blood, and then your body's demanding more oxygen as you're doing exercise, carrying grocery bags up 3 flights of stairs, you're going to experience the symptoms of your heart failure. So what is the goal of therapy? You want to prolong survival. You want to relieve symptoms, prevent the symptoms. You want to improve quality of life, and you want to try to slow the progression of disease. We know that you can't reverse it. Most of the time it's due to myocardial infarction. There's already dead tissue, or there's already tissue damage like thickened arteries, arteriosclerosis, and those can't be undone, but you can do what you can to help prevent them from getting worse. What's the drug therapy? Well, guess what? You're going to recognize a lot of these. They're used for angina to get more oxygen to the heart. They're used to regulate heart rhythm. They're used for congestive heart failure, and they're used for blood pressure. And it's because the whole cardiovascular system's tied together. So by benefiting by what these drugs do to the heart, they lower your blood pressure, which in turn benefits the heart. And same thing, what they do for blood pressure, well, it ends up benefiting whatever workload or load the heart's receiving or having to output. And so that's how come you're going to see these drugs on each one of the different topics in cardiovascular. So what's hypertension? Hypertension, medical term for high blood pressure. And the blood pressure is the product of cardiac output and the total peripheral resistance. So cardiac output, that's the maximum amount of pressure on your blood vessels when your heart's pumping at its hardest contraction. Then the total resistance is when the heart's completely Relaxed, how much pressure still remains in the blood vessels. So we have cardiac output. You don't need to worry about that. But preload and afterload. Preload, that has to do with the amount of blood coming into the heart. Afterload, that's the amount being pumped out. Contractility refers to if you just like clench your fist and squeeze it tight. Contractility, that's what your heart's doing when it pumps. Systolic, that's the top number. That's the amount of pressure when the heart's ejecting. So if you think about it, when the heart ejects blood, that's when the heart is exerting. It's when it's flexing its muscles, contracting. Diastolic is when the heart relaxes and fills. So systolic, that's the maximum amount of pressure in your blood vessels. Diastolic, that's the minimum when the heart's at rest. So whenever you see how does blood pressure expressed or notated, you're going to see a systolic over diastolic. So what is your blood pressure? And so for those of you who know, it's going to be something like my blood pressure is 130 over 70. If I wasn't taking prescription medications, it'd probably be like 190 over 105. So when you treat elevated blood pressure, there's a general rule of thumb that as long as your blood pressure, the systolic is less than your age plus 100, then you're good. So for example, if a 50-year-old man is 149, well, that should be good. However, they've discovered, now that people are living longer, living to be 95, 100, that the better control you have over your blood pressure, the greater the quality of your life, especially in those older years. And so you'll notice here, if somebody's over 60, well, you kind of reach a point where you say, okay, we're gonna be a little bit more flexible. Under 60, you went out under 140 over 90. Now, it gets much, much stricter. If somebody's got diabetes or kidney disease, they even drop this down to 120 over 70. But just understand that there's two numbers. This is the maximum pressure. This is the minimum. And as you get older, it's just a little harder to control the blood pressure. They become a lot more lenient. If you have a comorbidity like diabetes or pregnancy or kidney disease, they're going to want it lower. This is actually kind of a high number. What factors, risk factors, definitive? These are things that we know for a fact affect your blood pressure, your family history. So if you have a mother or father that has high blood pressure, that greatly or significantly increases your odds of having high blood pressure. Smoking cigarettes, not just cigarette smoking, tobacco, chewing the Nicorette gum, using tobacco chews, using vaping, a high-fat diet. Additional factors, you notice obesity, and then some medications, but obesity is probably one of the biggest ones. What happens when you have untreated hypertension? Remember I mentioned a minute ago, hypertension, it's a disease or a condition where you don't have symptoms. People often don't know that they have high blood pressure. Untreated, it's going to lead ultimately, it's like you're overworking, overburdening your heart. And so you're going to pay a toll. Over time, it's going to do heart damage. That's going to lead to heart failure. You're also overstressing or overburdening your kidneys, and then which ends up damaging the kidneys, ultimately leading to kidneys that don't work as well as they should. You get renal insufficiency. And then accelerated just means that the peripheral vascular and cardiovascular disease, they're going to happen much sooner than they would otherwise. So what do we do for hypertension therapy? The very first thing is modify your lifestyle factors. Most of us live a sedentary lifestyle. We don't get out and exercise and enjoy the outdoors and do physical activities as much as we could or should. What about our diet? Are you eating healthy? Are you eating balanced meals? Do you know, especially when you're younger, you can get away with anything. You can eat all kinds of foods that are unhealthy for you, but you're just going to pay the price later. Monotherapy. So doctors follow an algorithm. When you go to the doctor, if you have high blood pressure, first thing they're going to do is suggest that you try to modify lifestyle factors. You come back in a month, they check your blood pressure to see where you're at. It's very rare somebody's able to make a difference. It's just hard to change. They say you can't teach an old dog new tricks. After somebody's done something for years and years and years, it's just hard to go make changes. Monotherapy. So the doctor's going to pick one drug and place the patient on the drug. You want to give that drug a chance to work. And so you put the patient on the drug and you watch it over a couple of weeks, and then you can even increase the dose. You increase it as you follow just therapeutic guidelines, but you want to increase it to the maximum amount. Ultimately, you reach a point where you say, okay, this one drug, it's just not going to work no matter how high I change the dose. When that happens, you add an additional drug. And we follow an algorithm. There's a method behind which drugs are chosen, because you see all these, we've got beta blockers, ACE inhibitors, sartans, or the statin, sartans, ARBs, different classes of medicine for hypertension. So what does a doctor use to pick? We've got diuretics. When do you use a diuretic? When do you use a third drug? When you work in a community pharmacy, it's kind of a surprise for some people, but you're going to find patients that are taking 12 or 15 medications a day, 7 or 8 of which are just for blood pressure. So here's the pharmacotherapy. How do we approach treating hypertension? So a diuretic's a fluid pill. And diuretics, that's one of the first line, because just getting rid of extra fluid that's on your body has a whole lot of benefits. You're putting less burden on your kidneys, you're putting less burden on your heart, and it's a quick and simple fix. People feel, if you know anybody who has edema, it's just unpleasant when you wake up. If your fingers are so swollen, it's hard just to bend your fingers. Your ankles are swollen, and so just a simple fluid pill, and taking a fluid pill every day to regulate, get rid of that extra fluid. Of the fluid pills, of the diuretics, we divide them into 2 groups. There's a thiazide or loop, that's just one group, or a potassium sparing. And I'll go into that in just a minute, but the thiazide and loop, whenever they cause your body to get rid of extra fluid, that extra fluid's water, but whenever you expel that extra fluid, you urinate the extra fluid, you're going to lose electrolytes. And most importantly, you're going to be losing potassium. So if you don't supplement or replace the potassium, you're going to end up with too low of a level of potassium. Because of this, you have to be mindful. A patient needs to know to either eat a banana, orange juice. Potatoes have more potassium than a banana, but they have to know if you're taking hydrochlorothiazide or furosemide, you need to supplement potassium. Then we have potassium sparing, spironolactone. These, they're not nearly as effective of a diuretic as the thiazide or loop. However, you don't lose your potassium. So there's some medications that combine one of these and this to help minimize how much potassium is lost. Sometimes the doctors will use this just because they want to make sure the patient's potassium doesn't drop too low. Then we've got ACE inhibitors. We've got angiotensin receptor blockers. They're called ARBs. Calcium channel blockers. We've got beta blockers. And beta blocker is the drug of choice in congestive heart failure. So this you can print out, it's in your PDF of the PowerPoint, or you can just print out the slide, but I made this for you. This just shows you, this is the class. So we have diuretics, and there's a thiazide or the loop, hydrochlorothiazide or loop, and it increases your urine output. And when you have less fluid in your blood vessels, that means there's less demand on the heart, and the heart's not having to put out as much. Then we have an alpha-1 blocker. They end in zosin, Z-O-S-I-N, terazosin, prazosin. They indirectly cause vasodilation. When you dilate a vessel, that means it's less constricted. It means it's more relaxed. There's more room for the blood to circulate, so there's not as much pressure. The problem with the alpha-1 blockers is that if a person, especially elderly, if they're taking this medication and they stand up, there can be a sudden drop in blood pressure. It's called orthostatic hypotension. And it's so powerful that if somebody stands up very quickly, they can just fall over, or be so dizzy or drowsy or disoriented, they fall. It even happens if somebody's driving in their car and they just reposition themselves, and it can cause an orthostatic hypotension. So these aren't used nearly as much whatsoever. Then we have alpha-2 agonist. It decreases your heart rate and peripheral resistance. And I'll talk about these in just a minute, but clonidine, it's the only blood pressure medication. It comes as a tablet, an injection, but it also comes as a patch. And it's a patch that you apply once a week. You apply the patch, and then you put another thing that looks like a bandage on top of that patch. You leave it for 7 days and replace once a week. We've got renin inhibitors. You're really not going to see this much. And then combinations. I'll go through that in just a second. So thiazide and loops, what's one of their concerns? They decrease your potassium. Potassium sparing, they increase your level of potassium. Alpha agonists, they have that potential for orthostatic hypotension. Alpha 2, they have the orthostatic hypotension, but more importantly, they can cause bradycardia, which is your heart's beating slower than normal. Renin inhibitors, the reason you're not going to see them dispensed very often is that they can cause diarrhea. It's very bad when somebody first starts taking it. Usually with a medication, when you're taking it after a short period of time, those kind of side effects, they just fade away, but not with this one. The diarrhea just continues. The combinations, what happens whenever a brand name of a product loses its patent, and now all of a sudden they're going to lose all that money they were making when doctors were writing their drug. They'll find another generic product, combine it, and combine the two generics and create a new brand name product. And they'll tell the doctors, write this for the patient. A patient's more likely to take one pill and instead of having to take two different pills. But when you see the price differences, you're going to understand that really it's a terrible and greedy thing the drug companies do. So Catapress, it's the only antihypertensive that's supplied as a transdermal system. And once again, it can cause that orthostatic hypotension and bradycardia. It's also associated with depression. Now, something interesting about Catapress, this, I don't think y'all will ever have to be asked this, but if you administer it epidurally, it has to be diluted. But clonidine, it's used for people detoxing from alcohol or opiates. You can use either the tablets or the patch. But there's something about it stimulating the alpha-2 agonists that has some element or component related to, and it eases the symptoms of withdrawal. With the patch, one patch is applied every 7 days. There's a second patch, it looks just like a large bandage that goes over the top, over the first, to protect it. Here I just give, this is the earlier slide, and it just lists some of the things that you need to know, the pros or cons. So you cannot take thiazides or a loop if you're allergic to sulfur. So when we cover kidney and renal drugs, you're going to find that, you'll hear that again over and over and over. Diuretics, they make your skin sensitive to sunlight. So you have to put a sticker that says, will make sensitive to sunlight. If you're outside, wear a sunscreen or cover. So photosensitivity. Now with the potassium sparing, you've got to monitor your potassium levels. You monitor the potassium levels with any fluid pill. It's just for the diuretics, the loop, and the thiazide. You want to check to make sure they're not dropping too low. For the potassium sparing, you want to make sure they don't go too high. When do you take a fluid pill? It's taken in the morning, usually once daily. If you take it at night, you're going to go to the restroom all night long. You don't want to get up and down the running over the restroom all night, so you take it once daily in the morning. The one I mentioned, the terazosin and prazosin, is because of the orthostatic hypertension, people had dangerous falls and accidents, and so they're not used as much for blood pressure or at all. With the alpha-2 agonists, it can cause depression. You don't discontinue abruptly. The renin inhibitor, it's very rarely used just due to the diarrhea. Combinations, they do have improved compliance. So a patient will be more likely to take one pill a day as opposed to having to take 3 separate pills or 2. But look at this. Tenoritic, what they did is they took Tenormin, which was a brand name. It lost its brand name patent. So you could buy a Tenolol and hydrochlorothiazide. You could get 90 of the generic, these 2 generics, for $12. Or you could buy 90 days worth of this combination. So all they did was they just put a generic and a generic together, made it a brand name, and it's $700 with Diovan. When Diovan lost its its trademark, valsartan became available, valsartan generic. So what they did, they just combined valsartan, hydrochlorothiazide, they named it Diovan HCT, $320. So these combination drugs, it's very confusing. If people were paying cash for medicine, there's no way nothing would justify the convenience of a combination pill. But doctors write them because insurances have to pay for them, and insurance pays for them. As long as the insurance will pay, people will get them. But you can see why this is just abusing the market for the drug companies to make money. ACE inhibitors. Okay, guys, this is what the drug cards are all about. You want to nail the very most important parts of what's an ACE inhibitor. They end in PRIL. We have an agency called the United States Adopted Name Council. They assign every generic its generic name, and they pick the generic name based on its similarity or the drug class. So any drug that's an angiotensin converting enzyme inhibitor, you can rest assured the last four letters of the generic name are going to be PRIL. They inhibit ACE. ACE causes constriction in the blood vessels. By blocking this enzyme, it causes vessels to dilate. By increasing dilation, you're improving the flow rate and decreasing blood pressure. Here's just a few examples: lisinopril, enalapril, captopril, ramipril, benazepril. Side effects, okay? Elevated potassium. So that's what I'm trying to get across. When you look at side effects for drugs, you're going to see a billion side effects: headache, drowsiness, nausea, migraine, sneezing, just crazy because they have to list all the side effects reported during a trial. What we're looking for are the side effects that are significant, so side effects that we can anticipate because they're common, side effects that are important to know about so the patient can be alerted, and so as a healthcare practitioner, we know to watch. With ACE inhibitors, they elevate your potassium level. They can cause a continuous cough, and that's due to the buildup of the bradykinin. And when they first came out for just a couple of years, nobody put two and two together. We couldn't figure out why are our patients coughing. Angioedema, that's swelling that's under the skin, eyes, lips, or tongue. This is a type of swelling that's an emergency situation. It's very rare, but it's a side effect associated with an ACE inhibitor. If anyone has ever taken an ACE inhibitor and experienced angioedema, they will never take an ACE inhibitor again. And some warning signs. Main one is you've got to monitor potassium, especially if they're taking a potassium-sparing diuretic, and then do not take if you're pregnant. That's it. Then for your drug card, like if you have lisinopril, you can go look up the specific strengths. But you're going to find all these that they're given once or twice a day. They're how they're taken. Is it an empty stomach, with food, without? Is it taken in the morning? They're all, that part's all similar, but you can find out the specifics by looking into specific sites. But as far as this information here, you're not going to go find a magic website that's going to just enable you to copy down everything you need for your drug card in 3 minutes. You're going to have to actually work. But you want it to be work. Don't you want, by the time you finish this sequence, for example, if somebody's asking you questions about drugs, don't you want to know how to give them answers that would show that you actually spent time learning things, that you memorizing, versus, because who can't just Google, listen and read an answer to somebody? You'd be able to say like, oh, well, it can't be taken during pregnancy, and I do know it raises potassium, and it's got this weird side effect, a continuous cough. Now, these are just some examples. There's 1, 2, 3, 4, 6, 7, 8, 9, 10, and there's 4 more that are commonly used, and like another 7 more that are available. Once you know this, once you did a drug card over you all did lisinopril, it's going to apply to everything. ARBs, these are called like the cousins to the ACE inhibitors. All they do is they block, if they're the sartans, S-A-R-T-A-N, they block angiotensin II receptors. They prevent constriction and allow blood vessels to relax. So angiotensin, if you just remember, ACE inhibitors were angiotensin converting enzyme inhibitors. So this is just a different phase in the process. We haven't inhibited angiotensin. Instead, we're going directly to the receptors and we block it. And by blocking them, then we have the very same effect as the ACE inhibitor. So guess what? If you look, losartan, valsartan, candesartan, irbesartan, azilsartan, telmisartan, olmesartan, they're all sartan. Side effects, guess what? You're going to find it increases potassium, continuous cough. It's less than the ACE inhibitors, but it's still a side effect because of buildup of bradykinin. Angioedema, same thing in emergency. Guess what else? You monitor the potassium, do not take it for pregnant. So this helps just by understanding ACE inhibitor and then realizing this is ACE. What you're doing is you're just blocking the ACE receptor and realize and then identifying these are just kind of like cousins. They do very, very similar, very same thing. And then beta blockers. Beta blockers, they block beta 2 receptors. So remember, you got beta 1 in your heart, beta 2 in your lungs. Oh, that's a mistake. This should be blocked beta 1 receptor from epinephrine. So that right there should be a 1. I'll fix this. One unusual side effect, beta blockers can mask signs of hypoglycemia. So when a person's diabetic and their blood sugar is dropping down towards an unhealthy or unsafe level, there's a whole lot of signs that show, like sweating and paleness and then lethargy. And some of those symptoms, if a person's on a beta blocker, they're blocked, they're masked so that you don't notice them. With a beta blocker, one of the most important things to remember is you do not discontinue abruptly. If you do, if somebody just misses 1, 2, 3 days, 3 days worth, they can end up having a heart attack. They're worse than they were before they ever started the medication. We have beta blockers that are used for eye drops, for glaucoma. Glaucoma is a pressure in the eye. And they also discovered, they don't know the correlation, but people, if they take beta blockers prophylactically, it helps prevent migraines. Carvedilol is the one that's the most favorable in congestive heart failure. Then I mentioned earlier metoprolol. We've got metoprolol low tartrate. That came out first. So when I first became a pharmacist, we had low pressure. You had to take it twice a day. Then a decade later, they came out with metoprolol succinate, or Toprol XL. And XL is just like an extended release. It's just taken once a day. So I've seen this on the PTC before. It'll ask which metoprolol is taken once daily, and it's a succinate. Calcium channel blockers, Dipine, what was that? Dipine, boss, of the Fantasy Island, Dipine. So they stop calcium from entering the cells of the heart and blood vessels, making them more flexible, able to relax. Side effect, well, think about it. Calcium can cause constipation. Guess what? These drugs, one of their side effects is constipation. And then another common side effect is edema, that's swollen ankles. It is the drug of choice in African Americans or also if pregnant. Because remember, if somebody's pregnant, they cannot take ACE inhibitors or ARBs. And in African Americans, it has to do with the renal or the kidney system, but the ACE inhibitors and the ARBs, they're just not nearly as effective in African Americans. So for an African American, if they go to the doctor with high blood pressure or with congestive heart failure, the doctor's going to put them on a calcium channel blocker. And so you'll see here, verapamil and diltiazem, these were the first 2 calcium channel blockers. But then whenever they isolated, the next one was nifedipine, and the dipine represents a molecular structure. And then they noticed that was what's responsible for the action of the calcium channel blocking. And so then you see there's a whole slew of the dipines. Then myocardial infarction, that occurs when the flow of oxygenated blood to a section of the heart's blocked. So necrosis, when muscle tissue dies because of lack of oxygen. What causes a heart attack? Well, if you narrow the lumen of an artery. So if an artery is closed off by 70% or more, what are the risk factors? Angina. So angina is a warning. If your body's telling you, I'm not getting enough oxygen to my heart, that's a warning sign. It's only going to get worse. And unless you do something to resolve it, you're going to end up with a heart attack. Alcohol consumption. Reduced pulmonary vital capacity. So that means if somebody's got emphysema or COPD, this is why you keep seeing cigarette smoking popping up. Anything that is compromising the amount of oxygen that's being able to be breathed in through the lungs and then integrated or combined into your oxygen saturation, your bloodstream, to be disseminated throughout your body or into your heart. And the atherosclerosis is hardening of the arteries. Most common symptoms is the chest pain or discomfort, upper body discomfort, and shortness of breath. And many times people will say it feels like there's an elephant just standing in the middle of their chest. Other symptoms are cold sweat, unusual fatigue, nausea and vomiting, lightheadedness, and dizziness. What's the immediate treatment? First thing you want to try to open the arteries, get the blood pressure under control, and then you've got to regulate the heart rhythm. The acute phase, so immediately, initially, it's about getting oxygen into the bloodstream and circulating. Nitroglycerin helps to do that the fastest. That's why we have nitrostat is used during an acute anginal attack. Then aspirin. Aspirin does a couple of things. It helps prevent blood clotting. It's an antiplatelet agent. Then chronically, you want anticoagulant, a blood thinner. You want to help try to prevent an embolism. You want to prevent a future heart attack or a stroke. antiplatelets. Well, so the platelets, when they gather, when they stick together, then that's what leads to a thrombus. Then we have beta blockers, ACE inhibitors. These are medications that are going to control blood pressure. They're for congestive heart failure. They're for angina. Medications that treat cholesterol. And why is that important? Because cholesterol, they've identified, if you have elevated cholesterol, it's going to lead to hardening of the arteries. Hardening of the arteries is going to compromise your oxygen circulation in the bloodstream, which is going to lead to a myocardial infarction. So we're going to stop here. I'm going to pick up at thrombus on part 3.